Thank you very much. Welcome. Thank you very much, Simon, and everyone in the organizing committee for having me. It's an honor to be here. I'm Felipe Teran. I'm an emergency physician. I work in emergency medicine at University of Pennsylvania in the United States. I have a special interest in cardiac arrest resuscitation, and particularly in the incorporation of ultrasound in cardiac arrest. For the past 3 years, I've been very fortunate to work in two extraordinary teams that have, first in New York and later in Philadelphia, that have incorporated the use of TE, that is transesophageal echocardiography, during routine care of cardiac arrest patients. This unique experience has given me and my team a really new change and a new perspective in cardiac arrest. Has specifically changed the way we understand cardiac arrest, and has changed and challenged some of the paradigms of cardiac arrest resuscitation. It has basically made us also aware of how little we still know about how to best treat these patients. It has taken us back to the fundamentals of CPR. So today, I want to take you on a little journey to re-examine CPR, to rethink what we know, what we don't know, and to talk about a tool that I firmly believe can change and improve the care that we deliver to our cardiac arrest patients. I have a couple of disclosures to make. I've worked with a couple of these firms doing consulting work, and I've recently also received a grant to fund research that we're going to do in the animal lab with Dr. Norm Hardy's in a pseudo-PA model of cardiac arrest that was funded. It's been funded by the Zoll Foundation. I'd like also to acknowledge and start by acknowledging these individuals that have basically produced and advanced the knowledge in the field. The resuscitation scientists that you see here have described many of the concepts that I will describe today and produce the evidence. Chest compressions are, as you know, a fundamental component of cardiopulmonary resuscitation and a key component of the so-called chain of survival. One of the most important conclusions that we can draw back from the last couple of decades of resuscitation research is that high-quality CPR is the single most important predictor of survival and good neurological outcomes in cardiac arrest. We need to start early CPR. We need to do it hard and fast, and we need to minimize the interruptions. And this therapy hasn't really changed much. Hasn't really changed much since that original description 60 years ago. In this picture, you can see Dr. Kovenhoven here receiving cardiac massage by his friend and colleague, Dr. Knickerbocker, and a young James Ude on the left side, who were all together working on the development of an external defibrillator. At the time, Knickerbocker and Kovenhoven were doing experiments in dogs and realized that before they even discharged the defibrillator, they noticed that there was a raise in the blood pressure by the simple effect of their hands pressing on the electrodes on the chest. That simple observation led to the description of this closed chest CPR model that we know and practice until this day. And since that important observation, until now, 58 years later, not much has really changed in the way we do and perform CPR. So how does CPR work? According to that original description in 1960, it is the direct compression of the left ventricle between the sternum and the spine that ejects blood out of the left ventricle. This model was described at the time and has been known since then as the cardiac pump theory. This is an example of an intra-arrest TE demonstrating this model. We have a closed mitral valve on the left side of the screen, and that remains closed during compression, and we can see it very well, but at the center is the aorta that it's been opened during compressions. That is what happens every time we compress, and that's the cardiac model that was described originally. In 2018, We know that CPR physiology involves more than simply compressing the chest. Specifically, we have learned that there are at least two components in the process of CPR that have both specific and very important effects. In this diagram here from a recent review by Harris, we can see the hemodynamic effects of CPR in each one of these two phases, compression and decompression. During compression phase, we generate organ perfusion pressure. Basically, if you can think about that as your systolic blood pressure. During the decompression phase, we're essentially generating myocardial perfusion. And you can think about that as the diastolic blood pressure. That is effectively when the heart gets perfused, and we know that that is the most important determinant of achieving ROSC. But why is it so important from a hemodynamic standpoint? The reason is, during CPR, even if you are an Austrian that performs high-quality CPR every single time, at your best, you're delivering only 20 to 30% of normal cardiac output values. It is for this reason that we can't really afford to have any performance gaps in doing our cardiopulmonary resuscitation. In order to give our patients a chance, we must ensure that we're effective at this therapy. Let's take a closer look at CPR physiology. During compression phase, we essentially generate a sudden increase in the intrathoracic pressure. That leads to an increase in the aortic pressure that is responsible, for the most part, for our systemic flow. At the same time, increases the cerebral perfusion pressure. That is one of the variables involved in the generation of cerebral flow. During the decompression phase, we have the main mechanism involved is chest recoil. It's basically the re-expansion of the chest wall that generates a sudden drop in the intrathoracic pressure. It is that intrathoracic pressure drop that actually leads to venous return and sucks back all that pool of blood into the right heart, and that is responsible for myocardial perfusion during the decompression phase. There's a few problems with this description of conventional CPR. It's not a perfect model. First, during compression phase, we not only produce an increase in the aortic pressures and the cerebral perfusion pressures, but we also generate an increase in the right atrial pressures. That translates into higher intracranial pressures, or ICPs, and that impacts our cerebral flow. So ultimately, our ability to perfuse the brain during arrest depends on the balance between our cerebral perfusion pressures and our intracranial pressures. Second, during decompression phase, we know that after 10, 20 minutes of continuous CPR, we really alter the architecture, the structure of the chest wall, and we fracture some ribs. That leads to an alteration, a problem with the chest recoil effect. It's no longer good. That has as a consequence that we no longer can generate that effective drop in the intrathoracic pressure, and therefore we affect our preload, our RV preload. That, at the same time, affects myocardial perfusion and affects systemic flow. So can we somehow enhance our CPR? We know that myocardial flow and its surrogate coronary perfusion pressures are the most important determinants of achieving ROSC. Since we know that conventional CPR is highly inefficient, can we somehow enhance with interventions our quality of CPR? This has been the question that many researchers around the world have been trying to answer over the past 2 decades. I want to mention a couple of devices and one strategy that is still in the early phases of development. The first is active compression decompression device. And it all starts with this. This is how the story goes. Following dinner, a patient in the United States fell down, became unresponsive. The son realized that he wasn't breathing and started to give mouth-to-mouth ventilation. Didn't work. So he remembered that 6 months prior, his mother had resuscitated this gentleman successfully using a plunger. So he ran upstairs, grabbed a plunger from the toilet, comes down and starts plunging at his father. He did that for 10 minutes. By the time EMS arrived, the patient was breathing. He arrived to the hospital and recovered quickly. According to a letter to the editor written at the time by Dr. Lurie and his colleagues at that time at University of California, San Francisco, they speculated that not only did the plunger provide a precordial thump effect on this patient, but and provided effective chest compression, but also there was a significant negative pressure effect from it that they believed at the time was responsible for providing some ventilation to this patient. The patient recovered, and his son, who was feeling pretty good about having resuscitated his father using a plunger, went to the CCU to meet all the doctors and said, I think you should all get toilet plungers for all the rooms in the CCU so that they're available if this happens again. They had to agree with him. So they went to the lab, and over 5-6 years later, they developed the active compression decompression device, ACD CPR. This index case basically led to the development of this technology that in a series of small studies demonstrated that could increase coronary perfusion pressures and in some cases lead to better survival rates. I don't have the time to cover all the literature, but I want to mention that the second device that they developed that was related to this technology, also at University of Minnesota at the time, is the impedance threshold device, an ITD. This is essentially a pressure-sensitive valve that is attached to the endotracheal tube or any advanced airway and basically limits the negative intrathoracic pressure, limits the air coming into the lungs during the decompression phase. As a result, that enhances the negative intrathoracic pressure that we create during chest recoil. It's basically trying to enhance that natural decompression phase, thereby improves venous return and cardiac output. At least 3 randomized controlled trials assessed the use of these devices as an adjunct to conventional CPR. In light of that evidence, the current guidelines say that these devices are not recommended as routine use. However, they say that these devices can be used or reasonable as an adjunct in settings where the equipment is available and the personnel is trained. Many centers that are leading sort of the cutting edge of cardiac resuscitation, at least in the United States, are incorporating these devices as part of their algorithm when they can generate appropriate coronary perfusion pressures at the beginning of the resuscitation. Another interesting concept that is more novel and perhaps much earlier in the development and the stage of research is the concept of head-up CPR. And there's another interesting story to explain how this came about. See, in Korea, there are apartments that are really, really small, actually so small that can only fit 1 person at a time. These buildings have small elevators that don't really fit a stretcher. Therefore, when EMS comes in and they need to retrieve a cardiac arrest patient, they need to choose either take the elevator and put the patient head up or head down, or take the stairs. So a Korean professor from pre-hospital medicine came to visit Dr. Lurie at University of Minnesota and asked him if he had to choose which way would he recommend retrieving these cardiac arrest patients. Dr. Lurie ventured to say that head up would probably be the best for circulation. But he really didn't have any data to prove that. So as a good researcher he went to the lab and started working on the first experiments that later confirmed the clear hemodynamic benefit of resuscitating head up. Using a special tilt table, they randomized swine to receive CPR at different angles of inclination from head down to head up. And they demonstrated that when animals had their head at 30 degrees, they had significantly lower intracranial pressures, and that this also corresponded with better cerebral perfusion pressures. The animals that were resuscitated at more than 30 degrees head up, they also had higher coronary perfusion pressures. This is, as I told you before, this main surrogate of myocardial perfusion and the main determinant of the TV and ROSC. they also showed that when they reach this 30-degree angle, this pressure, the coronary perfusion pressures reach a plateau. And therefore, they concluded that that ideal angle inclination of the head was roughly 30 degrees. So summarizing what we covered, I told you that CPR really hasn't changed much over the past 60 years. I told you that in 2018, we know that there's at least 2 important phases that explain CPR physiology. Those are compression and decompression. Those are critical to achieve good resuscitation outcomes. I mentioned that the coronary perfusion pressure is the main determinant of resuscitation success and ability to get ROSC. And I described 2 of the devices that have been developed to try to enhance that conventional CPR. Finally, I mentioned the novel concept of head-up CPR. But most of these studies and the concepts that we have used to explain CPR so far are really extremely general. Still, there's many questions that remain unanswered. See, when we create compression, we increase the intrathoracic pressures, and we somehow generate systemic flow and cerebral flow. But what is actually happening inside the heart? What explains that forward flow? How does forward flow in CPR actually occur? And is the same mechanism in all patients? Well, this tool has helped us answering some of these questions. Transesophageal echo, or TE, has been used to study cardiac arrest hemodynamics since the early 90s. A handful of studies performed in that decade provided what we know now as the information that explains hemodynamics in cardiac arrest. Almost 2 decades after those studies, our institution, along with a number of other centers in the United States, have implemented the routine use of transesophageal echo during cardiac arrest resuscitation. Because its unique location behind the heart, T is not really affected by common limitations of transthoracic echoes, such as obesity, lung pathology, mechanical ventilation, and most importantly, it can be efficiently done without affecting the rest of the interventions, such as CPR. So using a focused protocol that involves only a handful of views, we can assess cardiac chambers, we can assess the valves, we can assess the great vessels, and assess for response to our therapies during cardiac arrest, and for dynamic changes that occur throughout the resuscitation. In this view, for instance, the ultrasound beam is parallel to the anteroposterior plane in which we're providing compressions. Therefore, it allows us to assess the quantity of that compressions, the effectiveness, and the area of maximal compression. Where is that LV compressed, if it's being compressed at all? There's an example of that during ongoing CPR in a 4-chamber view of TE. It's an example of a rhythm check done with TE. Usually takes only 3 to 4 seconds, and we can restart because it provides high-quality information and high-quality images immediately available. We don't have to struggle, as we do with transthoracic, obtaining those views during rhythm checks. There's an example of all 3 different views obtained in the same patient during the first 30 to 45 seconds of resuscitation, providing comprehensive information that can help us with decision-making basically within the first 2 minutes before even the first rhythm check. The first study that looked at this was in 1993 by Dr. Rita Riedberg in the United States, and they basically used transesophageal echo in cardiac arrest patients to look at what the valves were doing. They wanted to know what was happening during compression phase. They had roughly 20 patients, and they observed that during compression phase, the mitral valve remained closed, and that during decompression phase in older patients, the mitral valve was open. They also saw that the aortic valve was open during that compression phase. That was all consistent with the described cardiac pump model. In this model, as a reminder, the mitral valve remains closed during the compression phase, and therefore there's forward flow through the aorta, and there's retrograde flow into the pulmonary veins. This is an example of one of our patients demonstrating that concept. the mitral valve is closed, compressions are happening, and you can see how the aortic valve gets open to expel, to eject blood with each compression. This is another example of the cardiac pump model in one of our patients. You can see in a different view now. This is the aortic root. You can see how during compressions over the left ventricle, the aortic valve remains open, allowing blood to actually be ejected. But subsequent studies actually conducted in the late 90s challenged that concept of cardiac pump theory being the predominant mechanism in CPR. They demonstrated that there was a second model that actually accounted for that forward flow, and that model was the thoracic pump. In these studies, they proposed that there were a significant number of patients where it was a thoracic pump model that explained the forward flow, and that was happening by having a mitral valve that was open during the compression phase, and therefore the left ventricle and the heart was basically acting as a conduct, merely acting as a conduct, and the effect of the thoracic pressure changes is what was actually leading to forward flow. This is an example of that happening in one of our patients. This is the mitral valve. You see that leaflet there? The leaflet is completely open during the compression phase. That is how the thoracic model looks like. The mitral valve is open during the compression phase, and the blood can basically go through it in that phase as well. In line with those findings, and providing some additional insight to these mechanisms, Liu et al. Reported that, actually a lot more recently, that both models were actually seen in their cohort of, again, nearly 20 patients. In some of those patients, though, they also realized that there was dynamic change from the cardiac pump model to the thoracic pump model on the same patient. These are images that you can, from this original publication, that you can see what the situation of the valves is at 40 and 80 minutes. In the images on the top, you see the compression phase on the left, the mitral valve is closed, and decompression phase, the mitral valve is open. At 80 minutes, the mitral valve is open during the compression phase, and that is essentially the thoracic model. So the same patient went from a cardiac pump to a thoracic model throughout within their length of resuscitation. So they, for the first time, described that there was some dynamic changes in some of their patients in that small cohort that demonstrated that there was some dynamic progress within these two models. To challenge things even further, a third model has actually been proposed. Using color Doppler, this team assessed the direction of the flow in the pulmonary veins, and they identify what is potentially a third mechanism. This model has been referred as the left atrium pump model and came from the finding that the pulmonary vein had retrograde flows in some patients while the mitral valve was open. Therefore, in these cases, their theory was that the left atrium was actually acting as the main pump, generating flow in both directions. To contrast this with the thoracic pump model, in the thoracic pump model, we have forward flow in the through the pulmonary veins, and in the left atrium model, we have retrograde flow in that valve. Based on that, they propose a new algorithm. Basically, in cases where they saw that the mitral valve was open, they looked at pulmonary flow. If it was forward, they called that chest pump. If it was going backward, they thought it was left atrium pump. So there's at least 2 and potentially 3 possible models involved in a CPR. But why do we care? Why am I telling you this? Why do I think this is important remotely? What is the clinical application of this? Here's my vision. If we can assess, if we can identify these changes during resuscitation, we can potentially change the way we do CPR in these patients and optimize cardiac output in a way that is tailored to their specific physiology. But that is for the future. That is the science and the work that we're working on today in our research. But there are some practical applications of TE that are actually changing the management of our patients today. This is Dr. Amy Sadin, one of my senior residents, performing TE during one of our cardiac arrest patients. So what are those low-hanging fruit applications in practice-changing points of TE during cardiac arrest today? First, we can identify diagnosis. I told you, put the probe in right after intubation, even before getting to the 2-minute mark when we need to check for a rhythm. Cases like this, seeing clots in transit, clots that are in the context of a pulmonary embolism sometimes. In these two clips, you can see the descending aorta demonstrating a false lumen, a flap from a type B dissection. This is the cause of arrest in another case. We can't really assess the aorta effectively with any other means during resuscitation. Fine ventricular fibrillation. This has been well described in literature. It's basically patients where we see in the monitor and we have what we think it's PEA, but then we look at the heart and the heart is fibrillating. And in these patients, when we shock them, they actually come out of BFib. They get ROSC. So it only takes a couple of those cases to make you think, oh, maybe I've missed several fine ventricular fibrillations that I thought were actually PEA. With T now, we can see that. Some mechanical problems. Case of displaced pacemaker lead that perforated the intraventricular septum and likely led to the ventricular fibrillation arrest in this patient. This was quickly recognized with TE. Obstructive shock. Not that long ago, I had this case. Put the probe in, PA arrest, no ROSC in the field. This giant tennis ball in the right atrium causing obstruction. You can see that empty right ventricle. No matter how much CPR you do, this patient is not going to do well. We need to deal with that cause of obstructive shock. It's the same patient. On a bicaval view, we were able to assess the superior vena cava very effectively, and I could see how that thrombus was extending all the way up into the SVC surrounding a catheter this patient had. So that's diagnosis. We can also assess interventions that we made. The same patient that I showed you, we decided to give TPA and activate our team to put the patient on ECMO and potentially take the patient for thrombectomy in the OR. Minutes later, that clot, that tennis ball, was lysed. We were able to assess in real time our intervention and see the effectiveness. I could even look at the pulmonary artery and establish that the pulmonary pressures actually drop. And the physiology improved significantly with TPA, so much that when my colleagues from pulmonary interventional pulmonology came down, and I was thinking they were going to want to take this patient emergently to the OR, they said, we think the patient is now stable. We eventually got ROSC. The patient was treated with anticoagulation and taken for interventional radiology later. That's the same patient several minutes later with more expanded RV and eventually, again, obtain ROSC. We can optimize the area of maximal compression. This is what I personally think is the most promising application of TE in cardiac arrest. See, the effect of CPR, according to what I told you, the cardiac pump theory is we deliver forward flow by direct compression of that LV. However, there's plenty of evidence that this one-size-fits-all recommendation of compressing at the mid-sternum or internipple line stated in the guidelines doesn't really work for our patients. In fact, in many patients, we're not really compressing the left ventricle, but instead the LVOT or the aortic root. Not only this will cause low systemic flows, but even retrograde coronary flows have been documented. Plenty of studies from radiology documenting that the anatomy supports this. So this is an example of a case illustrating this concept. The image shows a mid-esophageal long-axis view of TE. In this image, we can assess the left atrium, the aortic valve right here, and as you can see here, the area of maximal compression in that case was occluding the aortic root in the LVOT. As you can see also, in that case, the aortic valve barely opens throughout the cardiac cycle because of that obstruction. Reflecting that finding, the diastolic blood pressure at that point was only 14, and the end-tidal CO2 was 18, as you can see here. This clip now shows ongoing CPR after having optimized the compression by displacing the Lucas, in that case, the CPR device, towards the apex, away from the base of the heart. As you can see now, the aortic valve is open appropriately, providing forward flow. A few seconds later, after repositioning CPR, our diastolic blood pressure, again, our best surrogate of coronary perfusion pressure, went up to 19, and the entitled CO2 is 26 at this point, and within a minute, the diastolic blood pressure had raised to 24, and the entitled CO2 was 31. Soon after this, the patient got ROSC. Kenton Anderson, a good friend and ultrasound-trained emergency physician at Stanford University, was thinking about this actually a few years ago, and he published with his team the first pilot study in animal that proved and validated this concept. It was an animal trial. They had swine with ventricular fibrillation, and they, based on those radiologic studies, they wanted to compare compressing the aortic root versus compressing the LV. So they used transthoracic echo to identify that position on the thorax, and they used T as well to confirm that more accurately. Using a thumper piston mechanical type device, they randomized animals to receive either aortic root compressions or left ventricle compressions. Once intubated, the animals had the T probe inserted, and they confirmed the exact location of the compressions. Then they kept the T in place throughout the resuscitation. The primary outcome was the coronary perfusion pressure. The secondary outcome was ROSC, because they really didn't expect to find what they found, and those were the hemodynamic parameters that they looked at. And they found that the mean coronary perfusion pressure was significantly higher in the left ventricle group. They also found that the aortic, systolic, and diastolic pressures and the entitled CO2 were higher on the LV group during all resuscitation times. Regarding survival, and this was unexpected to them, 9 of the left ventricle group, which accounts for 69%, achieved ROSC and survived to the 60-minute mark, compared to 0 in the aortic root group. Let me put this in perspective. What this potentially means is that all those 30 or 40% patients that we've been doing chest compressions over their aortic root, potentially they were in that category. Potentially they never had a chance to actually get ROSC because we were compressing the wrong structures. Of course, there are many limitations to the study. It was a pilot animal study, including the fact that because it's an animal study, doesn't really allow us to assess any patient-oriented outcomes. But we're working with Kenton right now on an observational perspective human study to further validate that concept in 3 centers in the United States right now. This is an example of that same concept in one of our patients. This is mechanical CPR being performed. The compressions are including the LVOT and the aortic root here. As you can see, you basically can't really see that aortic valve open at any time. This is the same case as the clip before, but now focusing on the left ventricle on a transgastric view. You don't need to understand much about CPR to know that that is really not working. That is ongoing CPR. There's really no pressure changes being generated in that left ventricle. This is another case of CPR with compression of the aortic, aortic root. As you can see here, again, if you play this frame by frame, there's 0 milliseconds where that aorta is open. So there's no way that we can have forward flow compressing there. This is another case of CPR using a mechanical compression device after having optimized the position, and we have a appropriately opening aortic valve. This is another example of ongoing compressions, again, with mechanical CPR device on the 4-chamber view. This is not the right plane to assess for effectiveness of the compression, but you see how there's squeeze of both ventricles. Ongoing chest compressions, another cardiac arrest. This is a patient with proper compressions where the aortic valve gets open. As you can imagine, you can get fancier and actually try to determine flows and get VTIs and quantify the cardiac output, and we're doing that in some of the cases. But many questions still remain. I'm going to only tell you a few of these questions that I personally want to answer. Pseudo-PA. With T, we've been able to capture patients that did not have a pulse, but then when we look at their heart on T, this is what they're doing. So this is not asystole, and it's not true PA. It's what's being called pseudo-PA. And we don't really know how to treat these patients. They're not perfusing, they're not generating a pulse. When we put an A-line, they get a pulse pressure, but we don't know if that pulse pressure is enough. We don't know how to interpret that. Some of us, many centers right now, believe that these patients should receive infusion of pressors as opposed to bolus doses of epinephrine and chest compressions. The rationale for that is that there's data from animals demonstrating that when you have the situation and you decide to do chest compressions, you have 50% chances to hit that ventricle during the diastolic feeling phase. And if you do that, it's essentially like stepping on someone's fingers while hanging from a cliff. So it makes sense, and there's some early data from Dr. Peretti's lab, who I'm working with right now, basically demonstrating that in cases like this, it would make sense to synchronize our CPR to that native cardiac activity. And that would probably be the best way to actually deliver CPR if we think that those patients need CPR at all. Aortic compression. I've seen this several times now. What does this mean? Do you see that descending aorta being compressed, squeeze? It's like intermittent aortic clamping during CPR. This happens a lot. What does that mean? Is there any implication in the post-resuscitation reperfusion injury caused by this? Can we alter that? Should we modify that? Is this a thing? We don't know. Large RV. There's normal RV dilation during cardiac arrest. Many of you have been trained to use echo during cardiac arrest, and you look at the protocols, and most of the protocols say, look for RV dilation during arrest. That could be a sign of PE. What they didn't tell you is that unfortunately there's a fair amount of data demonstrating that normally, naturally, during cardiac arrest, we have an increase in the volume of the RV that does not correspond with the increase of volume of the LV. And that is in the absence of pulmonary embolism. So this is something that we see all the time in the early phase of resuscitation, and that continues if we can't get ROSC. So many patients have an abnormally dilated RV. Look at the bouncing of the septum inward into the left ventricle. That, in this case, was not PE. It got better after getting good perfusion and obtaining ROSC in that patient minutes later. This is another case of immediate post-ROSC. Again, we see that often. And because we can see it more now, because we have a better way to assess this, it's becoming more important for us to know what to do with it. Do we call for thrombectomy? Do we push TPA? We don't know. We need to do more research to establish what is the meaning of this RV dysfunction. So intra-arrest TE has 3 important applications today. It can identify patients' specific hemodynamics during CPR. It can identify reversible pathology. It can help us to optimize the quality of our chest compressions. And for those of you in the audience who are thinking, the one thing I don't like is that you're doing an intervention, an invasive procedure during CPR, and the guidelines say that we should do everything possible to minimize disruption of the resuscitation and interruptions of CPR. This is a clip just to show you how little interruption and interference exists between the performance of TE and the resuscitation. This is the probe hanging from an IV pole during the resuscitation, and that's the screen. After completing the diagnostic scan, I routinely hang the probe and turn the screen to the rest of the team so that the screen of my TE becomes an additional monitor. All my nurses now know exactly what a 4-chamber view in TE is, and when they think that the monitor is indicating a non-perfusing rhythm, the first thing they do is that they look at the TE. And most often than not, they know exactly what's going on. They don't jump to try to get pulses. They look at the heart. So what are some of the lessons that we have learned using TE during cardiac arrest? The first important lesson for me is that the current algorithm we use in resuscitation, following this one-size-fits-all approach, where patients basically receive the same therapy regardless of their underlying physiology or their response to our therapies, this doesn't really work because patients have very different physiology. Second, we need to change this search, this absurd search for a magic bullet. It is not going to happen. We're not going to come up with a magic drug. We need to change the paradigm and stop thinking that we'll find a cure for cardiac arrest in a drug or in a device. Think about other important cases. HIV. In HIV, it wasn't a single drug. All drugs fail by themselves. But when put in a triple therapy, there was a coadjuvant effect that eventually led to the change of the natural history of the disease forever. So it wasn't each drug separate, it was a combination of drugs targeting at different components. And that is what many people in cardiac arrest community think we need. Cardiopulmonary resuscitation is a complex, multifactorial process. We need to start thinking in that dynamic approach. For that reason, I think bundle therapies targeting different components that have synergistic effect are most likely to make that significant difference that we need. And I would like to finish with a quote from an editorial in Resuscitation from a couple of years ago. We no longer can accept a treatment algorithm that where all cardiac arrest patients receive the same treatment. A patient-centric, personalized medicine approach is the way of the future. But our patients need resuscitation and now, today. So resuscitation scientists and rescuers alike should be feeling the pressure. Thank you.